Hi, everybody. Good afternoon. Thanks for spending some time with us this afternoon. I'm Deena Brecher. I am a pediatric ER nurse for about 26 years. Currently, I am the patient care lead for Mednition. But what we really want to talk about today are pediatric patients and pediatric triage. And I want to give a quick shout out to Marianne from New York State ENA for getting this all together. So I cannot see you, but I can see your chat. So please chime in, ask questions as we go. Don't wait till the end. I want to make this as interactive as a webinar possibly can be. So let's get started with a question. My first question for all of you is, when someone asks me to take care of a sick kid, so if you are logged into Menti, you'll see the question. If you're not, if you join, there we go, Ryan put it up there. It's also on the top of the slide. We will see what everybody thinks when they're asked to take care of a kid. Maureen, are you still unable to hear? One person says cry. Okay, here we go. Take a bathroom emergency. That is the best answer I think I've seen so far to this question. We'll give everybody a couple minutes. I know this takes a minute to get going. Everybody has a different experience when you're talking about taking care of a kid. For me, it was always, that's where I wanted to be. When you asked me to take care of an adult patient, I was not always my cup of tea. I love Say What I Can Do to Help. That is awesome. Again, if you're just joining us, there is an app that we're using called Menti to answer some questions. And so it says, the top of the slide, it says menti.com. You'll put a code in and you'll be able to give some responses. If you miss this one, no worries. We've got a couple more questions, same code, same everything. And so I love listening to parents. This is awesome. There is something that all of us in emergency nursing feel uncomfortable with, always, right? And even though I was a pediatric ED nurse, for me, I was always uncomfortable with congenital heart disease patients. And that's okay. That's part of what we do as nurses. And what I want to be able to get you through in the next 45 minutes or so is to feel a little bit more comfortable with common complaints that you'll see in the emergency department, some assessment tips and things so that you be more comfortable saying, you know what, I really need to be concerned about this patient, or hey, I think everything's good. So let's get started. We know from the Pediatric Readiness Survey that there are over 28 million ED visits for children less than 15 in 2014. And 85% of these pediatric visits occur in general emergency departments. So those of us that work in tertiary or quaternary pediatric care, we only see 15% of all kids that present to the emergency department. In addition to everybody seeing kids, almost 70% of those ERs see less than 15 kids per day, which makes it really a challenge sometimes to have enough exposure to sick kids to feel comfortable taking care of them. And that's, that is just like not having a specific adult patient, a lot of those patients. And so we're going to go through a couple cases and we're going to get through some of these answers. So first patient's a 2-year-old who comes to the emergency department after a seizure. The pediatric assessment triangle, the patient is, you're going to ask me, patient appearance that is awake, alert, no increased work of breathing, kid's pink, skin's warm and dry, sucking on a popsicle, happy to be here. Where do we go next with this patient? Had a seizure, is awake, alert, nice and pink, looks back to baseline. What is the most important assessment that we need to do? And you can put this one in the chat because I don't have a slide, a Menti for it. But what's the most important assessment piece of information we need to get to decide what to do with this patient? So think about your primary assessment. A, B, C, D, E. Think about vitals. What's the most important vital sign? History of fever. Outstanding. Thanks, Melanie. That is it, right? If this child had a fever, then we go down one pathway. If the child had a seizure without a fever, that's a different pathway. That's much more of a concern, an afebrile seizure. So we're going to talk for a sec about febrile seizures. So febrile seizures happen in kids from about 6 months to 6 years of age, although I've seen older kids with febrile seizures. In order to be considered a simple febrile seizure, they have to be neurologically neurotypical kids. They have to have a seizure that lasts less than 15 minutes. And they have to have generalized tonic-clonic activity, and they have to be back to their baseline when they arrive. Looking for things like head trauma, asking what the seizure looked like is important. All of those things are really important things to assess for any patient that comes in with a seizure. In this particular case, this 2-year-old did have a fever at home, was kind of congested, spiked a temp, and then had that seizure. So just remember, when you have kids that come in with seizures that are well appearing, if they have a fever, you're more walking down that path of febrile seizure, which is a benign situation. We worry more about what's causing the fever than the fever itself. But if I have a child who came into the ER who had an afebrile seizure, I start thinking of a lot of different things that may be going on. And the most common cause of an afebrile seizure in a child less than 2 is hyponatremia. So if you have a child, 18-month-old, who is seizing, you want to make sure that you're getting those electrolytes as quickly as possible. And you also want to ask the family what they're feeding that child and how they're diluting formula. But let's talk about fever for a second. Fever, your body's way of fighting an infection. I have a question for you related to fever. So in a 2-year-old, a fever is dangerous when the temperature is, and this would be multiple choice. Again, back on that Menti, we're going to be going back and forth to that. So let me know, in a 2-year-old, a fever is dangerous when the temperature reaches what temperature? Great. I'll give you all a minute. If you're just joining or you missed the last question, it's on the top of the slide. It says menti.com. You put the code in, you see the questions right on your phone, and then you can participate. So I know there's 40 of you, so we'll get a couple more responses. But I really, really appreciate you all interacting today. We've got a variety of answers. I love it. I love it. I love it. Okay. So here's the thing. The height of the fever matters much less than what the child is doing at the time. So if I have a child who's 105 running around the lobby eating Cheetos, life is good. Life is good. That child is interacting appropriately. If I want to know, is there a potential source for their infection? Are they congested? Do they have drainage? Are they pulling on their ears? Are they coughing a lot? What's going on from a source perspective? But I'm not worried about that temperature being 105. We give Tylenol, we give Motrin. Those things help make the child feel better. They make the parents feel better. And in some cases, they make the nurses feel better. But that in and of itself isn't going to change the outcome for that patient. If I have a child who's 101 and listless in mom's arms, I am very worried about that child and what's going on. So we, in the profession of emergency nursing, some of us think about fever as a number, and where I really need to be worried about what's going on with the child. And I want you to kind of put that aside. There are times when the number is important. So kids less than 28 days, if it's 100.4 or 38, depending on which world you live in, that's concerning. That's high risk all the time. Do not pass go. That is definitely something that we want to investigate. But once I get out of that neonatal period, if I have a condition where having a fever is a sign of a serious bacterial infection, like I'm an oncology patient, I have a central line, I have sickle cell disease, then really any temperature becomes concerning, and that those patients are high risk and they need to be evaluated for possible sepsis. But in a healthy child, 104, not a big deal, as long as they are acting appropriately at the time. Anybody have a question about that? I often get asked, can I prevent a febrile seizure from happening? And the answer is no. You can manage a fever, but there's actually no evidence that shows that giving, alternating between Tylenol and Motrin will prevent a febrile seizure from happening. Febrile seizures happen when there's a rapid change in temperature, which can either be up or down. They tend to be familial. And the number of kids that have more than one febrile seizure is about 30% of kids who seize may have another febrile seizure. Of that group, there is a less than 1% of those kids will go on to have epilepsy. So it's not a sign that there's something going on. It's just their body's way of managing a temperature change. Scary for the parents. So it's also important to remember how we respond to a child with febrile seizure is how the parents are going to respond to that same situation. So we want to obviously make sure the patient has a patent airway, is breathing well, is perfusing appropriately, and most of these kids are going to come to the ER and they're either going to be a little postdictal, slightly waking up, they may be yelling a lot, or they may be smiling and happy and the parents are freaked out, which I would be if it was my child as well. So let's move on to another case. So let's talk about a 3-day-old who comes to the emergency department with a history of vomiting. The parents report the baby's been fussy and not eating. When you look at the pediatric assessment triangle, this baby is awake and crying, has no increased work of breathing, and the skin is pale. So concerning for what's going on for this kid. When you do your assessment, you find that the baby's awake and alert, respirations are even and unlabored, cap refill is about 2 to 3 seconds. The interior fontanelle is soft and flat, and there's some dried yellow vomit on the baby's shirt. So my question, is this patient high risk? And so let's go. So answering that high risk question, what comes to your mind just with this information that's here? Awake and alert, cap refill 2 to 3 seconds, dried yellow vomit on the shirt. Do I worry about that? What am I thinking about? So am I thinking about pyloric stenosis? Is this norovirus? Am I worried about intracranial hemorrhage, volvulus malrotation? I'm not concerned. How wet the diapers are, that is one, yes, absolutely. But I'm going to give you a little bit more information on that. So if you're in Menti, go ahead and pick. If you're not in Menti and you want to just throw it in the chat, that's fine. I can do whichever way. So everybody's worried about this kiddo, and that is important. I definitely would be worried about this kiddo, but why, right? So somebody's not sure why, that's cool. We're gonna, at the end of this, you're gonna know why you should be concerned about this patient. We've got some norovirus in there, some pyloric stenosis, a little volvulus. So far, nobody's picked intracranial hemorrhage. And nobody's not concerned, so that's fantastic. So let's talk about pyloric stenosis for a second. Pyloric stenosis, more common in firstborn males. The story is baby is progressively increasing vomiting, and to the point that it becomes projectile vomiting. The best way to assess, unless you watch it, whether a baby has projectile vomiting or not, is to ask the question, when the vomit left the child's mouth, where did it go? If you ask a parent, hey, is your child projectile vomiting? They're always going to say yes. If you ask them where the vomit went and they said, oh, it kind of just went down their shirt, that's not projectile vomiting. If they say the baby looked like the exorcist and the vomit went across the room, that is projectile vomiting. The other hallmark thing you'll see is that babies are hungry. So they'll vomit and then they'll want to eat again. So this story that this kiddo doesn't sound like pyloric stenosis. You can get to bilious emesis from pyloric stenosis, but more often you'll see food formula, whatever, however old that baby is, you'll see that coming up instead. And they want to eat right after that. Norovirus is definitely, unfortunately, out there. We're going to talk about volvulus malrotation in a second. And an intracranial hemorrhage, anytime you have vomiting in a young child with no other symptoms, you want to be concerned about potential intracranial hemorrhage as well. And whomever put that answer in, I love it because you're thinking broadly. I'm worried about volvulus malrotation in this kid. So you have an incidence of 1 in 500 live births. You have something called midgut volvulus, where about 70% of these patients are neonates. But you can have up to 41% older than 2 months of age. So it's that same age grouping, or that age of patients that you'd see with pyloric stenosis. Malrotation is much more common in younger patients. So almost 90% of those patients are less than a year, so older than pyloric stenosis. But you'll find that half of them are less, a little more than half are less than 1 month of age, but you can see this in the first week of life as well. Why is this so? Why am I kind of beating this? You'll see formula intolerance for feeding intolerance. These babies will act like they have abdominal pain, and they'll have bilious emesis, hence the yellow vomit on the baby shirt. 77 to 100% of cases of volvulus malrotation will have bilious emesis. And here's why this is so important. If we rapidly identify and intervene with these kids, there's a 3 to 9% mortality rate. But when we delay diagnosis, so we don't identify these patients at high risk at the door, we're not getting them in front of the provider, and then for many of you transferred to somewhere that has pediatric surgery capability, you're looking at a 33% mortality rate. So when I'm assessing a baby, especially a young infant who has bilious emesis, that is always going to be a surgical emergency. That is always going to be a high-risk patient. Let's rule out something that has a 33% mortality rate. And we can see that at the door. So it's really, really important to just kind of stop for a second and go, okay, this is bilious emesis. This is a surgical emergency until proven otherwise in this age group. I need to make that patient high risk. Questions before I go on? And I do have one eyeball on the chat. As far as the question about wet diapers before deciding high risk, that's absolutely a really important question. If I have a baby vomiting diarrhea, if I have a child vomiting diarrhea, I want to make sure that what is going in is more than what's coming out. And so urine output is a really important part of that equation. And so I want to make sure that as I'm doing my assessment that I'm asking that question. Great. Fantastic. Okay. So let's talk about another baby. This is a mom who presents with a 4-month-old who fell out of the shopping cart. The baby looks just like this, awake, alert, smiling at you. Mom says the child was not strapped into the seat, leaned over the side of the shopping cart and landed on her head, and she cried right away. Has any of you ever seen this child? I have. More times than I can count, unfortunately. So head trauma in kids, very common mechanism. Falls is the #1 reason that we end up with head trauma. Traumatic brain injury results in over 400,000 ED visits every year in kids less than 14. And if you looked at all pediatric ED visits, you're looking 1 to 2% of those visits are kids with head trauma. And most of the time, it's not a big deal, right? I bump my head, I'm completely fine. Parents, again, get freaked out a little bit. But, you know, when you look at high risk, oftentimes it's a lot easier. If I have a 14-year-old male who presents after falling from a tree, confused, vomiting, waxing and waning levels of consciousness, hey, screaming high risk, right? A 6-month-old who's in respiratory arrest after falling down a flight of stairs with a bulging anterior fontanelle, definitely high risk. A 3-year-old who presents after falling off the top bunk, difficult to arouse, hypertensive and tachycardic, these are all trauma patients, right? But what happens when it's minor head trauma? They have these kind of maybe vomited once or twice, potentially had a loss of consciousness, it was brief, has a little boo-boo on their head, no behavior change, may have a headache. Those kids can be a little bit more of a challenge to pull out the ones that are fine and then the ones that really need to be seen quickly. And age is a factor as well. The older a child is, the easier it is to obtain a history. I love preschoolers, man. Like, there is nothing more fun than asking a preschooler what happened, because they will report exactly everything that ever happened to them, about why they're here. They also like to repeat things they overheard from their parents in the most inappropriate time and place. But they are a lot of fun. So the older kids, you know, once I get into that 2-3-year-old age, I can start getting a reliable history and they can tell me what happened. But kids less than 2 don't have those verbal skills yet. And so it becomes a lot more difficult in a child that can't tell you what's going on to really understand the level of risk for that kid. So we always, you know, talk about ESI, we're always going to start at the top, right? So is this child dying? If the answer is yes, they're an ESI 1. If they need an immediate life-saving intervention, they're going to be a 1. And then, you know, we look at high-risk situations. Bulging fontanelle, always a high-risk sign. A significant mechanism. I have taken care of many kids that have fallen out the second-story window, were caught by the angels on the way down and laid gently on the ground, and they do not have an injury. Still high-risk mechanism. We're still going to look at those children as if they are injured until they prove to us they're not. If I have a head trauma and I have other injuries, that's going to put me in that high-risk category. If I'm confused, lethargic, disoriented, obviously those kids are also going to be high risk. And then you have the parental, I just want to make sure that my child is okay, which is absolutely what a parent should be asking. So we make a big deal out of this because we worry about CAT scans and we worry about a potential increase in mortality from cancer for kids who get head CTs. We have a lot of policies now about ALERA, which is the lowest allowable radiation for a specific test, which is really awesome. And there's still some concern, and that the lifetime estimated risk for cancer mortality per one is 1 death per every 1,400 head trauma. The awesome thing is that there's growing consensus that CT is not indicated for all minor head trauma. So what we need to do at the front door of the ER is to be able to identify who needs a CT and who doesn't. Because if you're going to need a CT, likely you're high risk, you fall in that category. And if you don't, you likely fall in the low risk category. There was a study that was published years ago now from PCARN about the PCARN clinical decision rules. And what I found is that California ACEP did a fantastic job of making a graphic out of this. And so the idea here is, who are the kids that I need to scan? Those are definitely those high-risk patients. And so they divided it into kids greater than 2 years and then kids less than 2 years. So for a child who's 2 years or over, if they have a GCS less than 14, if they have signs of a basilar skull fracture or altered mental status, they're in that high-risk category. They have about a 4.2% risk of traumatic brain injury that requires surgical intervention. So still a small risk, but they fall in the high-risk category. If they don't have altered mental status and their GCS is normal and there's no signs of a basilar skull fracture, they're not vomiting, they don't have a severe headache, and they didn't have a severe mechanism of injury, those kids are very, very low risk, less than 0.05% chance of having a traumatic brain injury requiring surgical intervention. And so those kids are going to be really technically your ESI 5s. The group in the middle are the ones that we want to do a little bit more assessment. How are they now? If they have that severe headache, if they did have a significant mechanism of injury, those kids fall in the intermediate risk. It's still less than 1%. It's about 0.8% risk for traumatic brain injury requiring a life-saving or surgical intervention. But we want to work together with those families, providers, to make the decision that's in the best interest of those patients. Oftentimes, we're going to observe them. If anything changes, then we may go to CT scan. You'll have some providers that are more comfortable scanning some parents. So there's a lot in there. I just want you to be able to pick out the ones that really, truly are high-risk patients, and then the ones that you can feel comfortable saying, you know, this kid's going to be just fine. So we have the same clinical decision rule with a little bit of an age-appropriate adjustment. So we're talking about kids less than 2. So here, we're looking for a palpable skull fracture, right? It takes a lot of force to fracture that skull. So I'm going to want to make sure I palpate. So if I have a GCS less than 15, if I have altered mental status when you see me, or I have a palpable skull fracture, those kids are high risk. They have a 4.4% risk of traumatic brain injury requiring surgical intervention. So I want to get those kids back as quickly as possible. If none of those things exist, they're awake and alert, they have no palpable skull fracture, and they are not altered, then I look at a couple other things. So I'm going to look, do they have scalp hematomas? Now, fall down, go boom on my forehead is not a big deal. Kids get those big goose eggs on their head often. But if that hematoma is anywhere else but here, then that kid's gonna move into that intermediate category. If my loss of consciousness was more than 5 seconds, and that's a hard thing to truly measure, because time kind of either goes really fast or really slow when there's an emergency happening. And so the family may not be able to adequately let you know, hey, this patient, there's a, less than 5 seconds or more than 5 seconds. They may say he fell on the ground, had his eyes closed. I called his name, he opened them. Okay, so that's probably less than 5 seconds. So you need a little bit of detective work in your assessment there. So if I look fine when I get here and I don't have any signs of skull fracture, and I didn't have severe mechanism, I'm acting completely fine, my loss of consciousness is less than 5 seconds, and I have a scalp hematoma on my forehead here, then those kids are the low risk kids. They have less than 0.02%, less than 0.02% likelihood of having a traumatic brain injury requiring surgical intervention. And so hopefully that helps with the kids that I'm worried about, the kids that I'm definitely not worried about, and then the ones in the middle that we need a little bit more information to figure out what's the best course of action for those kids. So with all that, let's go back to my cutie patootie. So this is a 4-month-old who fell out of a shopping cart. Child's awake, alert, smiling at you. The mom states the baby leaned over the side of the shopping cart and fell, landing on her head, and she cried right away. What do you want to know about this child? So from a pediatric assessment triangle, we gave that to you. She's well appearing, her airway's patent. She has no increased work of breathing. Her skin color, temperature, moisture, cap refill, all normal. From a disability perspective, you don't palpate any abnormalities. Baby wasn't vomiting, is acting appropriately now. There's no hematoma at all. How would you prioritize this patient? Does this kid fall in the high risk category or the low risk category? Any vomiting? No hematoma. Great question. High risk, low risk. And I'll even put this back for you so you can see it. So GCS is less than 14, or the GCS is 15, no palpable skull fracture, no altered mental status. So I'm going to go the no route. No scalp hematoma, no loss of consciousness greater than 5 seconds, completely acting normally for the patient, for the parent, and no severe mechanism of injury. So that will take that patient to that low risk category. Some of you are disagreeing, and I'm really, really glad you are, because there's something about this patient that doesn't apply to this, to the clinical decision rule. And that is the fact that this 4-month-old leaned over the side of the shopping cart and fell, landing on her head. So if I took that part out, then yes, this child's low risk for sure. But a 4-month-old sitting up, leaning over the side of the shopping cart is not normal growth and development for this age. And anytime I'm in a situation where I have an infant who was alleged to be doing something that they shouldn't be doing at their age, I worry about non-accidental trauma. And that's always going to make this patient high risk. And yes, I tricked you a little bit, but I did it on purpose. If I took that out and, there was a good solid story for how this kid hit her head, the dog was running and knocked the car seat over, and the baby was in the car seat, that's a plausible story. But leaning over a shopping cart and falling out is outside of what I would expect to be appropriate for a 4-month-old, and that's what puts this baby in the high risk category. But great, you guys are doing a great job asking great questions. So speaking of questions, when do you measure blood pressure on a pediatric patient? I get asked this question all the time. Those who know me know my answer, but I'm really curious. This is another Menti question. So you can put it in Menti, you can put it in the chat. When should we measure blood pressure on a pediatric patient? Okay, always. Depending on chief complaint, whenever possible. Cardiac patients. Told you I got eyes on both. I'll just wait another minute. 3 to 5-year-olds. Unresponsive, yes, please. I'll just wait another minute. Anybody else? You agree? Congenital heart disease. Yep, always. Any unstable at over 5 every time, always. I've gotten more always today than I'm used to getting, and I love it. So the answer is really always. And I say that when you think about the fact that that most 85% of pediatric patients come to ERs that see less than 15 kids a day. How do you know what's abnormal if you're not used to looking at normals? How do you know where the equipment is? I do a lot of data analysis. We looked at an emergency department, several emergency departments. We were working on kids with respiratory distress who are less than a year of age. And we looked at 1,000 records and ran lots of experiments, and we couldn't figure out why everything was looking wonky until we did a distribution of the respiratory rates. And out of the 1,000 kids, 93% had respiratory rates documented of 18 or 20. So if we are not assessing and documenting correctly on pediatric patients, and we only do it once in a while, we're not going to be as skilled at it, and we're also not going to know necessarily where our equipment is. So the recommendation for me is always, if obviously you're doing a blood pressure and triage, but the patient needs to be in a room, put them in a room. Do the blood pressure. Blood pressures and triage should never get in the way of starting care on a patient, but they are really important. The American Academy of Pediatrics, I'm glad that we're seeing those 3 and 5-year-olds. At 3, we screen kids for hypertension. And so there are some ERs that have taken that as we should start that screening in the emergency department, which is great. I love it. But I encourage you, because kids will not always be what we think they are when they come in the door, and that is very specifically true about non-accidental trauma. With that being said, having that blood pressure, that first blood pressure on arrival, gives the next nurse something to compare it to. If I don't have that initial blood pressure, and now this patient's more sleepy than they were, but it's 2 o'clock in the morning, it's a lot harder to see trends and which direction is this kid going. Am I tired, or do I have something going on in my head? So getting that blood pressure is is ideal to get it on everybody. Yes, renal cardiac issues, hands down. Yes, absolutely. Congenital heart disease, yes. Whenever you can, if the child's cooperative, yes. And if you cannot get a blood pressure, but you know that you have good, strong peripheral pulses and good cap refill, document that. So we know that you assess that. I have a question about head circumference. 26 years in the emergency department, never, ever measured head circumference unless it was a concern for hydrocephalus. That's it. And I've worked in many freestanding pediatric hospitals, and it's just not something that we do from an emergency perspective, except for that small group of infants. And even then, I'll say if it was already established, we didn't necessarily do a head circumference, but if it's a new diagnosis, we were concerned or something changed, then we would. So if you're doing it, that's great. You know, sometimes we do things because we've always done them that way, and sometimes we do things because things have changed since the last time I looked at the literature. So I encourage you, if you are doing them, to just do a little investigation and then, you know, decide when you should or shouldn't do them anymore. You'd obviously do those on the younger kids, not the older kids. But great, and we do vitals on all patients. Yes, I love that. Thank you guys. That makes a huge, huge difference. Okay, so we've talked about head injury, we've talked about fever, we've talked about seizure, we've talked about volvulus malrotation. So now we're going to talk about headache. This is a 5-year-old who just graduated high school, by the way. A 5-year-old who comes to the ED complaining of headache. She's also afebrile and is complaining of some nausea. Mom denies any medical history. Patient has no allergies, takes no medications. And so there's lots of things that go through your head, right? She looks great. She has a headache. What do I do with that? And so a little bit about headaches. More than 90% of school-age kids have had a headache. It accounts for about 1% of pediatric ED visits. And the kids come for lots of reasons, right? Sometimes the headaches are getting worse. Sometimes they took some Tylenol and the headache's not getting better. And sometimes it's just for reassurance that there's nothing bad going on. So when we think about headaches, these are the same patterns you see in adult patients. So you have primary headaches, migraines, tension headaches, cluster headaches. They're usually self-limiting. They have patterns. And secondary headaches, which are a headache as a result of something else. And so they have identifiable etiologies. The vast majority are benign, but you want to look for life-threatening causes. Kids with strep often have headaches associated with that, and belly aches too. You always want to look for the life-threatening causes. So things that I'd worry about from a secondary headache perspective: infection, intracranial hemorrhage, and mass, carbon monoxide poisoning. I know we're getting out of winter into summer and we skipped spring, but something to think about. Hypertension is another situation that would cause a secondary headache. Common things that cause secondary headaches that are not life-threatening: fever, pharyngitis, viral meningitis, otitis, sinus infections, dental abscesses. And then you have your migraine headaches and your tension headaches. So very, very similar, minus the fact that kids get otitis more than adults do, but similar etiologies from a headache perspective. So history is really important when you're looking for headaches. So the onset of headaches, is it, yes, visual issues, yes, kids that have not had their eyes checked in a while or ever, straining from the blackboard, and will come a little bit in the timing perspective, right? So the onset, is it abrupt? Has it progressed over some days? Timing, is it an hour before school starts? Does it wake the child up from sleep? Is it late in the day? All things that will point us in different directions. Acute headaches, so it's a single episode of a headache without history. So this is more of this is my first headache. I don't have a history of headaches. It's likely to be caused by something else. So think infection. That is the most common cause that you'll see. Recurrent headaches, they have consistent describable characteristics. And so I always get a migraine. I get this, or my left eye does weird things, and then I get the headache, I start vomiting. And it happens that way every single time. But if they have migraines and then what they're saying is it's different than normal, you have to look for other causes. Don't just put them in that migraine box because there's likely something else going on. Chronic headaches, headaches that are progressive, they increase in severity and frequency over time. That's when you want to start thinking of some kind of space occupying lesion, some kind of mass or tumor. Headaches that are chronic but don't progress, they tend to be more tension type headaches. I can have a frontal headache. I can have a temporal headache from the school age vision changes. I just recently got new contact lenses, and so I have new reading glasses, and I will tell you that I already have a frontal headache because I'm not wearing them right now. And so I have a little bit of eye strain going on. Other associated symptoms besides the headache, fever obviously will point you in the direction of infection, change in mental status or meningeal signs, always concerning, always high risk. And then other localized pain. Yeah, my throat hurts or my ear hurts or gee, my face hurts, or those dental infections. If I have a headache after trauma, I want to think about, could this be an intracranial hemorrhage or other TBI, and I can use those decision rules to pull out those high-risk kids. Is this an environmental cause? So several family members with sudden headache and nausea, I might think carbon monoxide poisoning. Hey, it was field day, now I have a headache. I could be dehydrated, it could be sun-related, right? Visual acuity changes can be ocular migraines, but they also can indicate intracranial hypertension. So vision changes, or visual acuity changes especially, would make those children high risk. Parents will come into the ER worried that the headache is not just a headache. They may have a family member, relative, friend who had either had or know someone who had a brain tumor. A little bit of what makes you, why are you concerned today about this? It can help you kind of unravel that. But the thing is that these kids with brain tumors almost never present with just a headache. Most are going to have that chronic progressive pattern, so the headache's getting worse over time. You'll also see things like vomiting, especially progressive vomiting or vomiting on awakening, that I wake up, I sit up, and I vomit. That's that change in, or that increase in ICP when I do that. These kids might have behavioral changes. They may have polydipsia, polyuria. They may be complaining of vision changes. They may have some other neurologic symptoms. I'll never forget a high school friend of mine posted a picture of her son and a little, that he had headaches, and a little description of what was going on. And just in the way his eyes were, and some of the things she described, I knew right there what was going on. And unfortunately, I was correct. So it's not just going to be a headache. It's a headache plus something else that would tend to lead you down that path. I took care of a patient a very long time ago, was transferred from urgent care for rule-out appy. He came in, we had a set of vitals from when he left urgent care. He had intermittent abdominal pain. He also had intermittent vomiting, no fever, normal white count. The ultrasound that they had done did not show appendicitis, but we kept thinking it was appendicitis. And he had ptosis when he arrived. He became bradycardic. When he came in the ER, his heart rate was 20 beats per minute less than it was when he left urgent care. His blood pressure was going up, which we wouldn't have known if we didn't have that first blood pressure. And ultimately, he became unresponsive. And he had a brain empyema. But his story, when you go back and think about it, the fact that he had intermittent abdominal pain, and a headache that was consistent, vomiting, especially in the morning, those things, and then the ptosis was the big giveaway. Those things all say space occupying lesion. And so it's important, just because somebody's being transferred with a label, that we don't do that diagnostic momentum thing where we all just try to put his symptoms or put the patient's symptoms in that box, right? we need to step back and say, hey, this doesn't make sense for what we're seeing. Let's step back. And you'll see that with kids that come in that have brain tumors or space occupying lesions. So a couple more things. If they're ill appearing, they may have a serious cause for their headache, and you want to consider those patients to be high risk. Vital signs, blood pressure, really, really important. This is the time when that change in vital signs, that change in heart rate and blood pressure are going to tell you what's happening. And then from a resource perspective, these kids may need imaging, they may get an LP, and then obviously labs as well. Last case. So this is a 14-year-old female who comes in with chest pain. She was chasing her brother. She was dizzy, thought she was going to pass out, and she's asymptomatic at this time. If I asked you, chest pain in a 14-year-old is always high risk, needs an EKG, is never high risk, or depends on the situation, where would you put chest pain in a 14-year-old? I have a depends on the situation. Somebody's very fast on the survey, which I love. Always high risk. Get that EKG. And I've got high risk and needs EKG, depends, see EKG. We've really gotten dependent on that EKG. So it's going to depend on the situation. So chest pain in kids is different than chest pain in adults. It is a population of patients that tends to be over triaged. And so hopefully at the end of this, we'll be able to, again, differentiate. So common symptom in children and adolescents, half the kids who come to the ED with chest pain are less than 12. Lots of anxiety in parents, especially in families that have a history of heart disease or have a family member who has a history of heart disease. Frequently, there's no serious underlying medical cause for the pain, and up to 45% of kids with chest pain will have no identifiable cause for their pain. And cardiac disease, rarely the cause of chest pain in kids. Not never, but rarely. Musculoskeletal causes of chest pain are the most common cause of chest pain. Respiratory causes, things like having a history of asthma, will give me that potential for chest pain. And then there are a few cardiac things that cause chest pain in kids. We see a lot of psychogenic causes for chest pain, breast causes, pulmonary vascular disease, and then toxic exposure and neurologic conditions can all cause chest pain in kids. So it's not just cardiac. History, really, really important. You want to include the description of pain, the associated symptoms, same things you would do from an adult perspective. Past history, substance abuse, really important to ask that question. And if you're talking about adolescents, older school age and adolescent kids, you want to ask that question in private if you want an answer that is appropriate. Underlying medical conditions. So these are things that would make me concerned if a child comes in with chest pain. Sickle cell, acute chest, high risk, don't pass go. Kids with a history of Kawasaki disease. I worry about those kids. Even if the Kawasaki was in the past, I worry about coronary artery aneurysm dissection. So those are high risk. Kids, asthmatics with moderate to severe bronchoconstriction, those kids can have chest pain. I worry about those kids with chest pain. What's going on? Why are they so tight? I need to intervene for those kids. And then any underlying cardiac disease with chest pain is a high risk for serious causes of chest pain. Kids with Marfan have a history. They often die from dissecting thoracic aortic aneurysms. Yes, happy to share slides. No worries. We just have to figure out how. I'll leave that to Ryan. Tell me more about your pain. So same exact assessment that you're doing in adults, the same thing, sharp, minimal radiation tends to be more of a costochondritis, where that squeezing, tightness, pressure tends to be more of that ischemic. Same cause, same description of pain in kids and adults. If I can localize, I can take one finger and point to where it hurts. That's more likely pleuritic. If it radiates, I start to think again about that myocardial ischemia. If it hurts more when I move, diabetics, yeah, diabetics, we forget that kids are diabetic. Kids are on blood thinners too. We tend to forget that. So history is important, puts you more at risk. So other associated symptoms, if I have a fever and chest pain, it's probably a respiratory infection. If I'm short of breath, think pneumonia. Vomiting or heartburn, I might have reflux or esophagitis. And then the somatic symptoms, headache and abdominal pain every day I come home from school or every morning before I go to school. Syncope and palpitations. Those two things with chest pain are going to point me down a cardiac pathway. Great question, Maureen. Has COVID changed assessment of PD chest pain? Not that I am aware of, but that's definitely something I'm going to look into. I have not had that question, so that's a great question. Concerning sickle cell with chest pain while running, chest pain and palpitations, sudden onset of chest pain in a lanky, tall 14-year-old, all things I'm concerned about. But chest pain after being yelled at my dad or eating sausage and peppers, not something that I need to be concerned about, high risk. I need more information, more assessment if I have infection and chest pain. The child's ill appearing, obviously I worry. If the vital signs are outside the norms for the child's age, I want to think more about what's going on, potentially cardiac. And then if parents tell you, hey, they have a cardiac history but can't tell you anything else, ask if they see cardiology and how often they go. They say the kid's 14, we were signed off from cardiology when the kid's 2. It's probably not cardiac chest pain, or probably not related to whatever that was. But if they are supposed to go every year and they haven't been, I'd be more concerned that whatever that history was is concerning for what's happening today. So this kiddo's not dying, not high risk because they're completely asymptomatic, but definitely needs a workup. So it's going to need that EKG, labs, and a chest x-ray likely. So I was going to do a quick pop quiz, but I know we only have 5 minutes left. So let me just go here. You don't have to answer this question. I'm just going to give you the answer for time's sake. Make sure when you're listening to a 6-month-old that you listen to the baby. You auscultate the heart rate. Always, 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 right? I want to auscultate. I want to then make sure that I have good, solid peripheral and central pulses. Putting the baby on the pulse ox, you're going to miss SVT every single time. The pulse ox doesn't tell you anything about the quality of the pulse. Is it regular or irregular? It's just going to give you a number. And so please make sure in kids under a year that we're actually auscultating heart rates. Pediatric ESI is available on the ENA website on the triage page, which I believe is ena.org/triage. But if not, then I apologize for that. I had one more, gratuitous picture of my nieces from 10, 15 years ago now, which is scary. Anybody have any questions? And then just for those that are interested, after I answer all the questions, I have about 10, 15 minutes about Kate, AI at Triage, that I'm happy to share with anybody that wants to stay. But happy to answer questions.